Hi everyone, welcome to the Center for Innovation in Campus Mental Health webinar series. We're just going to take a minute for the attendees to populate our list before we get started, about 1 to 2 minutes. Hi everyone, thanks for waiting. Thank you all for joining us today. The topic today is opioid overdose prevention and harm reduction. So just some housekeeping before we get started. Participants are on mute while we are on the call. You are all in listen-only mode. We will be taking questions at the end of the webinar, so feel free to type in your questions using the question function, and we will start taking them up around 1:45. The webinar is being recorded and will be made available on our website, campusmentalhealth.ca. And if you look under the handouts function on your screen, you should be able to download a PDF of the presentation today. This PDF will also be made available on our website. We do have a short survey at the end of the webinar, so please take a few minutes to complete it as the feedback is really valuable to us. Now, I'd just like to introduce myself. My name is Perlin Ng. I am the Research and Knowledge Exchange Coordinator for the Center, and we are joined today by Catriona Remocker and Dr. Tim Dyck from the Center for Addictions Research of BC. Say hi. And right here, we have Jean Hopkins from the Canadian Mental Health Association Ontario Division. Thank you all for joining us today. I'm just going to read a brief bio for everyone. Catriona is a research associate with the Center for Addictions Research of BC, a PhD student in social dimensions of health at the University of Victoria, and a registered clinical counselor specializing in family systems therapy. She spent 5 years as project manager for the Changing the Culture of Substance Use project within the Healthy Minds, Healthy Campuses community of practice after completing her master's in public health in social and behavioral health sciences at the University of Toronto. She continues to act in a consultative role to the Healthy Minds, Healthy Campus and provides guidance to both governments and campuses on how to consider and address the opioid crisis from a community engagement and health promotion perspective. And Tim is a research associate in the Vancouver Knowledge Mobilization team of the University of Victoria Centre for Addictions Research of BC. He contributes to stewarding the Healthy Minds, Healthy Campuses community of practice and the Changing the Culture of Substance Use initiative. He actively supports reflection and discussion around a consistent health promotion and culture perspective as a framework for addressing substance use on campus and in communities. Jean is a policy analyst for the Canadian Mental Health Association. She leads the Addictions and Complex Care portfolio, where she focuses on drug policy and substance use treatment as it relates to community mental health and addictions in Ontario. Jean has previously worked as a clinical social worker in the addictions and mental health sector and has a Master of Science from the McMaster's University Global Health Program, where she studied international drug policy in Lisbon, Portugal. All right, and I'm going to turn it over to you guys in BC. So, yes, Catriona, yes, here we go. Okay. Perfect. Yes.
Perfect. Well, thanks for that lovely introduction, Perlin. We really are so pleased to have been invited to speak on this topic, one that we've been working on here in BC for quite some time. So I've been asked just to kind of give some background and context to the opioid crisis that's been affecting us across Canada. And so I thought a little bit of history would help us just kind of contextualize what we're seeing today. So I'll get right into it. So just some background. So what do we know about opioids and where they've come from? So opioids have been around for a very, very long time, of course. Opium has been used recreationally for thousands of years. Morphine has been relied upon actually as a painkiller since the early 19th century and was widely relied upon during the American Civil War. Heroin was actually accidentally invented and developed in 1874 in an effort to produce a less addictive form of morphine. And then eventually we turned over to the development of synthetic opioids in the 1960s. But at that time, these drugs were really only seen to be used in cases of extreme pain or end-of-life pain care, such as cancer. And so this is around the time that we saw the emergence and development of fentanyl, which we now have heard of and is so common in the media. So around the 1990s, though, we saw a bit of a shift. And so at this time, we really saw the pharmaceutical companies looking to expand their profitability of their existing drugs and find better solutions as well to historically undertreated chronic pain. And so a handful of pharmaceutical corporations began promoting the prescription of opiates by family physicians. And this is when we saw OxyContin, pictured on the right there, began to be promoted as a potential to relieve chronic pain because it relieves pain for 12 hours at a time, which made it an attractive option for those with conditions like rheumatoid arthritis or fibromyalgia, which tend to present in chronic pain form. We also saw at this time that the American Pain Society championed opioids as the fifth vital sign. And so this was a really big change in attitude around how we were treating these drugs. Now, the main issues were that GPs at the time were often poorly trained in pain management and misinformed often about how to safely prescribe these drugs. And there were few monitoring systems in place to really track patient use. We also saw that there were conflicts of interest. So pharmaceutical companies were actually accused of, and there was quite a significant amount of evidence to back this up, of providing incentives to doctors as well as developing educational materials that were distributed through medical schools, such as textbooks that were actually authored by the pharmaceutical companies on these drugs. Another piece that came into place was a practice of doctor shopping, which became a common practice among patients who became dependent on these drugs to manage their pain. There was really just poor regulation at the time and very little monitoring of prescriptions. And part of the problem, of course, was also that patients developed tolerance to these pills. So that wasn't really taken into account when they started to be developed and prescribed, this idea that tolerance would become an issue. And so sometimes patients found that their pain wasn't really taken care of over the full 12-hour time span. And so they began to increase their own dosages in order to manage their pain better. So although the stats will tell us that really only 1 in 130 folks who is prescribed an opioid will actually develop a kind of dependence on it. Because we saw such a dramatic increase in the number of prescriptions being doled out, the number of folks who did become either dependent or developed subsequent harms such as overdose as a result of these prescriptions was on a significant rise over the time span between the 1990s and up to the early 2000s, around 2010. So the big question that I like to ask, though, is what are the conditions that actually made it so favorable for an actual opioid epidemic? And the reason I ask this is because one thing we know in epidemiology and public health is that outbreaks happen all the time. And so you can think about this in the disease context. So for instance, the Ebola outbreaks, these have been tracked over time, and there have been lots of outbreaks over the years of Ebola. But what are the conditions that were needed to take place for an actual epidemic to take hold, as we saw in 2014? And so the piece that we often think about in public health is that the conditions have to be favorable for this to happen. And so some of the factors with Ebola that were identified were actually population growth at the time, poverty, poor health infrastructure. These were main factors, along with increased human activity and landscape alteration in Ebola virus reservoirs. So some particular conditions had to take place in order for this to become an actual problem that it was. Drug epidemics are very similar, but a bit more complex because, of course, drug behavior is mediated by social behavior. And so we have to think of it within this context. What are the social behaviors? What are the conditions that are affecting social behaviors that actually lead to a problem of epidemic proportions? So this is where we turn to the data to start thinking about what kind of story it can tell us. One piece, I looked at this data, and I'm showing you BC data. I apologize that it's not Ontario data. We crunched this data last year, and when things started to really kick up here in BC. And the reason being that we wanted to look at and think about whether or not the trends that we were seeing here in Canada and BC in particular were similar to those that were being seen in the US. And so we might think about it within a similar context. And what we found is that, in fact, the trends were very similar. And so my thinking is that really we could have crunched some Ontario data, but trends are probably pretty similar over there. So one thing to note, and so I'll just direct your attention over to the statements on the side of the slide, is that what we're finding in the opioid epidemic is the number of overdoses are significantly more, males are being more affected than females. So this has been the case for a very long time, but the ratio in 2007 was 3-to-1 male overdoses to female, and it has simply increased. So it's now 4-to-1. So although among long-term chronic users of opioids for non-cancer pain tend to be female, the majority of ODs are actually younger males. And so this is actually a suggestion that the deaths are not among those that are being prescribed opioids. They find that the majority of those who OD are not found to have an active prescription in the months prior to their death. Another piece that we're finding is that folks are increasingly younger who are ODing. So in 2007, the majority of ODs, the highest percentage we saw of ODs was in the 40 to 49 category. And this has shifted to be significantly younger. So we're seeing the highest rates now in the 30 to 39 category and equal rates in the 19 to 29 category as the 40 to 49 category. You can imagine that shift in trend over time. And finally, another trend that's really emerged is although that we're seeing the majority of overdoses in urban centers, in fact, the issue is affecting the rural areas at a disproportionate rate. So per capita, we're seeing much higher rates of overdose in rural areas, and it's shifting to be more and more. So I like to think about what us? What story do we start to see emerging? And the story that I see when I think about my background and what I know about opioids is it starts to tell a story about an issue where the most vulnerable folks were actually those who were, rather than extremely marginalized folks, actually young male workers in the blue collar industries in more rural areas. So areas that are more dependent on resource extraction and things like that. And so what you actually see is that as jobs in these industries have been eroded away over time, many of these communities have really suffered. And so and one other piece of that is also that folks in these types of jobs tend to become injured at pretty high rates, and then they were often being put on opioids in order to deal with those injuries. And so there became a process in these communities as these communities broke down, as there were fewer opportunities over time, more and more folks started to use these drugs. They were in greater circulation recreationally. And so we saw a big shift in communities as they broke down and greater vulnerability community-wide. And one thing that can occur over time when you see this kind of trend is that we then see what we call a kind of cultural shift. So a cultural shift is really what happens when a behavior that was not considered acceptable in the past now becomes normalized and is considered acceptable. And so the use of opioids recreationally has really seen a shift in people's attitudes over time around how they use it. And that's why we see what we start to think about as the beginning of a tipping point. So where it's no longer just folks who are very, very marginalized, experiencing significant harm, but also folks who are really just using recreationally, socially, and not necessarily would it be seen as high risk, so to speak. And so this is where it starts to come in and start to expand through the population, through our culture, and affect our campus communities. And one other piece that really has contributed to the very high end of this tipping point are what we think about as regulatory efforts and the dried up supply of heroin. So, and these are really tied together. So, noticing when governments noticed the trends in opioid use, they really started to see that they had to step in and do something. Now, when we think about drugs, governments tend to go, when they see an issue like that, they tend to go towards the idea of we need to crack down. So the actions that were taken were really mostly around increasing policing efforts, restriction of and tamper-proofing popular opioids. OxyContin is a good example of this. Retraining and educating doctors in their prescribing practices, regulation of the pharmaceutical marketing practices, introduction of the computer monitoring systems to keep track of prescriptions, and cutting down on doctor shopping practices. And so while that could be seen as a good effort, it tied in with what we saw as a crackdown also on the heroin supply. So heroin supplies began to dry up. It's unclear a little bit at this time if that's simply a lack of supply or also a lack of ability to import supply. And so we started to see also drug lords starting to bring in synthetic opioids because, of course, they were much easier to import in smaller quantities while still having really significant potency. And so that's where we get to this point where we're really looking at a very, very tainted drug supply. And so folks have no idea often what they're getting in their opioids when they're buying them, no longer from legitimate sources. And so we've seen the result of this being, although opioid prescriptions have now declined significantly, deaths from synthetic opioids have increased dramatically in the last few years. And so this is what brings us into the current context today. And I'll hand things over now to my colleague Tim, who really will give you a sense of now how this ties into our campus communities and what we can do and how we can think about it from a community engagement approach.
Okay, so the question, what can and should we do? There are two widely recognized and somewhat contrasting avenues of response here. One is use prevention, which often takes the form of measures to ensure that people cannot use and messaging to the effect that they should not. Several questions and issues actually arise around this line of response. How realistic is it? How effective has it proven to be? To what extent is it legitimate? How willing is it to relinquish institutional or organizational establishment control? How respectful is it of individual agency and autonomy? And at times, is it even counterproductive, introducing unintended harms? And because of concerns around this, many people are attracted to a second line of response here, and that is that of harm reduction, really seeking to decrease the likelihood and or severity of harm in connection with use. And harm reduction seems eminently appropriate, and we're going to have opportunity to consider some applications of it in this very webinar. But there are questions in relation to it as well, and some could be, is it as attentive and appreciative enough as it needs to be in regard to the motives for use and the benefits of use? Thankfully, it saves lives, but just how much of a change can it actually bring about? Is there, therefore, a more substantial, inclusive approach that can be taken, one that contains harm reduction within it, but not at its very core? So the more encompassing and substantive framework that I'm going to commend to us here today really involves three facets, at least, that I wish to feature. Three aspects that are very distinguishable and yet are actually interrelated. They're complementary, they intersect, and they even overlap. In short, doing health promotion, pursuing cultural change, and engaging in dialogue. And I'm going to expand a little bit upon all of them in a few moments, but for starters here, in terms of health promotion, this is really about, for individuals and communities, expanding and extending their capacity, their opportunity, and their action to take increased control of their well-being. Pursuing cultural change, helping people together to be more shapers of than just shaped by factors of influence around them. In other words, how can people help actually to shift a culture rather than to simply absorb it and assimilate to it? And engaging in dialogue, involving people in conversations that are geared to better shared understanding. And arguably, we cannot really do health promotion in the robust sense on a collective level without pursuing cultural change. And we cannot really bring about culture change that enhances wellness without engaging people in dialogue. So just with respect to health promotion, what really distinguishes it here as I'm offering it as an alternative approach? Well, to begin with, it's this broader, more encompassing and positive concept of health as being physical, mental, emotional, relational, social, economic well-being. In contrast to a narrower and more negative one that focuses on preventing and treating illness and injury. Now, health promotion is not indifferent to disease and damage, but arguably it sees itself as the best long-term way of actually bringing about a decrease in the occurrence of that kind of damage. Health promotion is really attentive primarily to collective well-being. And at a collective well-being, health will manifest itself in communities that enjoy, for example, inclusivity, cohesion, that is mutual respect, trust, and accountability, shared literacy, widespread participatory engagement, increasing equity, impartiality, social justice, access and opportunity, shared wealth, sustained improvement in living conditions. There are ways in which we can measure the well-being of communities. And the socio-ecological approach that's involved in health promotion is one that recognizes really different kinds and directions of influence among diverse factors that bear on health, that operate really across and between various levels of dynamic interaction that individuals have with their more immediate and their more extended surroundings, those spheres that are interpersonal, institutional, community, and societal. Health promotion is, as we indicate here, intersectoral, multidisciplinary. It really involves combined strategies. It can't just be the responsibility of healthcare personnel. And this really answers to the complexity of influence on health that includes influences on substance use. Another real hallmark of health promotion is this empowering thrust that it has, affirming individual and collective agency, building bridges and bonds and a sense of belonging among people, and enhancing literacy. And by literacy, I mean skill and capacity to really improve health. So, culture change. Health promotion seeks cultural change for the better. What does cultural change mean? Well, it's helpful to think of culture as that layered set of presuppositions and persuasions, values and attitudes, practices and symbols that is shared by a group and that gets transmitted and reinforced through mechanisms of socialization. Culture is typically transparent, that is, not apparent to its possessors, and it really provides an implicit framework for shared identity, meaning, communication, and behaviors. There are some really helpful metaphors in this regard regarding culture as the lenses through which we look out on our world, the invisible medium through which we all swim, the software that drives our social autopilot systems. And given that nature and reach of culture, changing it therefore means helping ourselves and our fellow campus members together, collectively, to be more perceptive and reflective about the common basic assumptions and beliefs that we have, to be more attentive and constructively critical and analytical about our shared values, our dispositions, our stances, what we approve and reject, what we really embrace and what we dismiss. To really be more intentional, more deliberate, more purposeful about the popular social practices that we otherwise would just routinely engage in. To be consciously collaborative in choosing and pursuing goals and means to better our situation. So, in this sense, if dialogue is really then the answer, or well, not the answer, but a mechanism, actually, a very helpful mechanism for engaging in cultural change. We need to understand it in terms of its distinctiveness too. And dialogue really is a way of being with others. It's an orientation, a way of being with others, and an approach to or a manner of communicating with them that fits with that orientation towards them. Dialogue then involves a distinct sort of conversation in which the parties to the conversation are really actually listening attentively to one another and doing so with a view to enhanced understanding. Dialogue is the kind of exchange in which participants are really open and receptive to gain perspective from others' insights and stories, and to do that towards what Gadamer calls a fusion of horizons. Dialogue really is one in which the people that are involved are really looking to learn. It's an exploratory venture. They're raising questions that prompt reflection among themselves. They're entertaining possibilities. They're examining assumptions, including one's own. It's really an encounter and an exercise that actually is inclusive and receptive of others as fellow citizen learners, peers, equals, partners, co-contributors in generating knowledge and in gaining increased reasoned response to matters and arriving at those. It's one that really doesn't privilege professional experts or defer to people with political power. And I say here, it's a way of relating that's very comparable to a motivational interviewing approach. Many of you may be quite familiar with that, the approach that has been commended to us by Bill Miller and Stephen Rolnick. And that's especially about conversations that you have with individuals one-on-one. But if we look at it in a broader context of dialogue, the approach to conversation in both dialogue and in motivational interviewing is very, very much akin. They're both non-authoritarian, non-prescriptive, collaborative, non-manipulative. They are very attentive and eliciting and encouraging in their character. And really they're marked by respect, compassion, empathy, acceptance, appreciation, affirmation. These are some of the distinguishing marks of what dialogue is. It's really helpful for us to recognize and appreciate what it is not. It's not an instrument or a tool for a quick fix. It's not a method, a technique. It's not really a way to practice how that we can, well, it's really not the way that we in health communication generally tend to speak. So I've got these, and I'm not sure that I'll really work through all of them actually in the interest of time here, but we need to reflect that dialogue is not something that we ordinarily do and naturally do, but it's something that's really special and better than that, and can be cultivated and can work in a very beneficial way for us in terms of really acting together and supporting one another and encouraging one another. Even the difference between dialogue and discussion, because often discussion can really involve batting an idea around about until it ends up on top. And this is one that's really instead very attentive to what the other is saying and what the implications of that might be for a different perspective on our own part and on the part of our group together. It doesn't really involve reaching agreement, but it's very important towards that as a preparation and a foundation for that, and the same with problem solving. Dialogue can be an important part of that. It should really precede it, and it really should continue in it. So I'll let people in the aftermath of the webinar think a little bit more of these contrasts because the presentation will be available to you afterwards. How do we engage dialogue in it? And I'm conscious that here I am advocating for it in a format that's very non-dialogical. Really, it's a matter that there is no particular fixed process or set of steps or measurements that we must match to really produce dialogue. It's a principled approach, and I ought to have really used gerunds with ing, like reaching and planning and welcoming and empathizing and listening, rather than infinitives that kind of look in this list like imperatives. These are really kind of features, characteristics, components of dialogue. And it's all about building relationships in which we really identify divides as an opportunity rather than an obstacle. And that we consider suitable settings that we can conduct it in that are appreciative of where everybody is coming from, and that we welcome people into it, and that we really empathize, we identify with them as best we can, and listen carefully, acknowledging their contributions. And if need be, we really start small in it and work up as we can as the means of gradually achieving a better understanding of each other in the process. So that's a really rushed view of it. But if dialogue is really not a quick fix, then what's its benefit in a time of urgency, of crisis? And in some, I would say it's the benefit of helping a community come to a position in which it can collectively proceed to act collaboratively in really appropriate, respectful, responsible, accountable, insightful, supportive, meaningful, useful, proactive ways, with better prospects for long-term benefit, rather than in well-intentioned but artificial, arbitrary, authoritarian, prejudicial, blind, unhelpful, unhealthy, reactive ways that actually may be disadvantageous in the short and long term. So we're building bridges here that are sometimes spanning divides that have been deep and wide as between those who use and those who don't, and other gulfs too can be spanned. We're shaping a context of meaning and belonging. We're fostering a climate of care and cooperation. We're encouraging an ethos of shared advancement. And there's plenty of attestation at different levels of personal relationship and community for the value of dialogue. And in our own changing culture of substance use provincial community of practice, that's composed really of local COPs that compose it, that comprise it, we've really found ourselves inspired and enabled by dialogue to pursue in a concerted way a variety of initiatives to promote healthier relationship with substances. So we're not authorities on this. We're novice practitioners. We're learning, but we are finding it very compelling as the way to move forward in terms of relating to challenges around substance use. I have some resources that are listed here. I'm not going to actually elaborate them at this point. You can check them out again at your leisure, because I want to make sure that Jean has time to proceed with her presentation.
Thank you so much, Katrina and Tim. That was a really great introduction to the opioid crisis and also the importance of dialogue. So I'm just going to switch this back and voila, show this window. Okay. And oops. Okay, we're back.
Okay.
And I'm going to turn this over to Jean in a very quick second. Just going to pull up your presentation.
Great. So my name is Jean Hopkins. I'm a policy analyst at CMHA Ontario. I'm the lead on the addictions and complex care portfolio. So thank you, Tim and Katrina. That was really helpful in sort of providing some history and some context into what we're currently dealing with the opioids crisis in Canada. And some really great approaches as well, Tim, so thank you very much for that. I'm going to be spending the next 15 minutes or so discussing a couple of resources related to opioids. So the first is a resource developed by CMHA Ontario to support organizations that are wanting to implement an overdose response protocol in their organization. And the second is a resource on opioid treatment options that was developed by the Centre for Addiction and Mental Health. So the Canadian Mental Health Association, we have 30 branches across the province, and we're really seeing the impacts of the current crisis at our branches and with the clients that we serve. We're also aware that there's other organizations that are seeing the impacts outside of the mental health and addiction sector as well, like campuses, for example, that are in need of information and tools to be prepared during this crisis, and they aren't necessarily sure where to start. So this resource, Reducing Harms, Recognizing and Responding to Opioid Overdoses in Your Organization, was developed to assist in supporting organizations that want to train staff to implement an overdose protocol, which might include naloxone as well. So this is grounded in a harm reduction approach, which Tim mentioned. It's an evidence-based approach that seeks to reduce the health and social harms related to substance use, but without necessarily requiring people who use substances to abstain or to stop. And some of the key elements include really taking a pragmatic approach. So the recognition that substance use is inevitable in a society. So instead of saying, you know, it's not a problem, it's not something that we need to really consider or worry about, it's an approach that's proactive and says, you know, there are potential harms to substance use. How do we take a health-oriented approach to minimize some of those potential harms, which clearly we are seeing with the current opioid crisis. It also takes into consideration individual choice. So again, really speaking to a number of Tim's points about building relationship and engaging in dialogue. It's a non-judgmental approach to people who might use substances. And it focuses on the harm, so not necessarily on the substances of themselves. And I think it's also really important to note and to clarify too that this approach doesn't support or condone substance use, but rather it's an approach that seeks to open up a broader conversation in order to minimize potential harms. So before jumping into the resource, I think it's also important to give a little bit of information about the current context in Ontario currently. Just wondering if we could change the slide over.
Yes.
Great, thank you. So, yeah, and again, Catriona gave a really great background into the history, and that's very similar to what we've been seeing in Ontario. We also know that Canada has one of the highest rates of prescriptions for this class of drugs in the world, and the overprescription of opioids has definitely contributed to the current crisis that we're in. So, for example, 80% of people entering residential treatment for opioids were first exposed through a prescription. Among young adults, ages 25 to 34, 1 out of every 8 deaths is due to opioids. So again, similar trends to what Catriona was mentioning with, we're seeing harms with increasingly younger populations. Fentanyl is the leading cause of death, opioid deaths in Ontario, and hydromorphone, also known as Dilaudid, is second. And of course, you've probably heard quite a bit about fentanyl and high-potency drug supplies being sold on the street, contaminated drugs. Unfortunately, I'm not able to speak to that at length, but I know that there is a link to a Globe and Mail video that might be helpful to provide a little bit more information and context into what we're currently seeing. On the right here, too, this graph shows the most recent data around some of the harms related to opioids. So you can see the number of emergency department visits and hospitalizations since 2003 to 2017. And the most recent data shows that there were at least 865 people that died as a result of opioids in 2017. So currently, that's an overdose death that occurs every 10 hours in Ontario. And we're really not seeing these numbers slowing down. So, as I mentioned, many organizations are wondering, what can I do, and where do we go from here? And I want to discuss Naloxone and the resource that we at CMHA Ontario are offering as well. So, Naloxone, Narcan is its brain name. It's a medication that can reverse the effects of an opioid overdose, so it's an antidote to opioids. It can be delivered either intranasally, so through the nose, or intramuscularly, given through an injection into a muscle. And on the right, you can see a diagram here. So opioids impact the respiratory system, which can lead to someone's breathing slowing or stopping if they ingest too much. And naloxone blocks the opioid receptors in the brain and reverses the effects of an overdose. It's also really important to note, too, that naloxone only works for a short period of time, which is why it's really important to treat an overdose as a medical emergency and call 911 as soon as possible. So the Ministry of Health and Long-Term Care has been attempting to make this as accessible as possible to people who might be at risk of overdose and to their support systems as well, by making it available and free from pharmacies since June of 2016. So naloxone is a Schedule II medication, which means that it's available without a prescription, and it's intended for use by lay people, people without a medical background, in the event of emergency. Naloxone also only works for opioids, so if someone is unconscious for another reason, say they've consumed too much alcohol, administering naloxone won't be effective. And it's also important to note, too, that there won't be any negative harms to the body if it's administered to someone who is not experiencing an overdose. So on the left, you'll see the intramuscular naloxone kits, and these are available through the pharmacy program. So you'd receive 2 vials and 2 syringes. And on the right is the nasal spray, the Narcan nasal spray. So where do you obtain naloxone, and where are the distribution points? So there's two main streams. So naloxone can be obtained through the Ontario Naloxone program for people who meet the criteria listed here. And no health card is needed. It's also important to note that correctional facilities are also now distributing them at discharge for those that might be at risk. And that's because people who have a past history of opioid use who are being discharged from correctional facilities are at a much higher risk, approximately 12 times higher than the general population. And on the right, we have the Ontario Naloxone Pharmacy Program criteria as well. So you can obtain a intramuscular kit if you have a health card, and also brief training if you access naloxone from either one of these options. I would also encourage you to take a look at the link that's at the top of the page. So this is a Ministry of Health site that will give you information about where the nearest distribution point, and distribution points currently are expanding. So yeah, if you take a look at this, the website here, you'll have a better understanding of where the nearest one is in your community. So while naloxone is available to people who meet this criteria, there really isn't anything, there aren't any concrete supports in place for organizations that are wanting to implement a protocol to be able to support their staff in recognizing and responding to opioid overdoses. So the document that we've developed is really meant to fill these gaps and to provide all of the possible options so that staff can be trained to implement a protocol and to respond in the event of an opioid-related emergency. So we really want to provide current and relevant information about opioids and naloxone in Ontario. And some of the overarching goals are to assist organizations to develop and implement an overdose prevention and response protocol that's really specific to the needs of that organization and the people that they serve. We also provide infographics on administering naloxone as well as templates for policy development. So the idea being that we're making it as simple as possible for your organization to develop something. And really, we want to encourage naloxone to be a part of any first aid protocol. So in the same way that your organization might have defibrillators on site or train your staff in CPR, we really want overdose recognition and response to be an extension of your current first aid protocol, given the current climate that we're seeing with the opioids in Ontario. So some of the topics covered in the resource include a deeper understanding of the harm reduction framework, which we previously discussed, as well as an understanding of who might be at higher risk. We discuss administering both intramuscular and intranasal naloxone, as well as what aftercare looks like. In addition to that, we also discuss issues around stigma, ways to talk to clients about safer substance use in a non-judgmental way, so to engage in dialogue, with a real focus on prevention and also on normalizing conversations about substance use and also safer use. So yeah, engaging in dialogue and contributing to culture change, very similar to some of Tim's points. In addition, we also want to, we also recognize that, two of the major questions are, two of the major questions are how to go about training staff to recognize and respond to an overdose, and also where to obtain kits, whether that's intranasal or intramuscular. So we provide various different options, including information about obtaining naloxone directly from the manufacturers as well. We also include a section on frequently asked questions that break down some of the myths, and suggestions around debriefing and distress prevention as well. So with the recognition that responding to an overdose is an extremely difficult situation, especially for people that don't necessarily come from a medical background. So how does your organization ensure that everyone, both staff and clients, are being supported after an overdose-related emergency? And we also cover additional considerations around equity, how to monitor and evaluate your protocol, discussion of Good Samaritan legislation, developing a communication strategy to let the broader community know what sort of work you're doing, and with the intention of really decreasing the stigma around substance use, and also about talking about safer use as well. Finally, again, I mentioned this before, but we also will be providing templates and infographics like the one that you see here to know what to do in the event of an overdose. But the intention here is also to send a broader message to the community that staff at your organization are informed, that substance use is something that is safe and acceptable to talk about within your organization, and that staff at your organization are equipped to respond. So really the overarching goal is to ensure that organizations that are being impacted or might potentially be impacted by the current opioid crisis have the information to be able to educate themselves, to respond, and we hope that this document will be helpful in supporting organizations that are wanting to implement a protocol. And again, we really encourage naloxone to be a part of any first aid protocol and to really normalize a potentially life-saving medication. So this resource is going to be coming out in the first week of November. We're in the process of doing some final revisions, and you can find it on our website at ontario.cmha.ca. I do have another resource from the Centre for Addiction and Mental Health. In the interest of time, I'm not going to spend too much time talking about it, but I do think that it's definitely worth mentioning. It's an incredibly helpful resource called Making the Choice, Making It Work. It was previously known as Methadone Maintenance Treatment Client Handbook, but it's been updated to reflect the changing landscape of opioids, the changing demographic of people who are seeking opioid treatment, and to also expand, and also an expansion of treatment options that goes beyond methadone as well. So it's CAMH's most popular publication, and for good reason. It provides a lot of helpful information about a treatment option called opioid agonist therapy. And it's a resource for anyone who might be considering this treatment or want to support somebody who might be currently struggling with substance use related concerns, and or for people who simply just want more information. That's okay. All good. So some of the topics include frequently asked questions, information to help people choose between opioid agonist therapy and other treatment options, a methadone and buprenorphine comparison chart to see what might be the best fit for someone, information on side effects and interactions with other drugs, information on counseling and its benefits, role of opioid agonist therapy in sexuality, pregnancy, and family, a checklist to assess tapering readiness, and additional contacts and websites for more information. So it provides information regarding evidence-based opioid treatment options and helps people to understand what the expectations, benefits, and restrictions of this treatment option. And generally speaking too, it provides a book for not only clients, but also friends and family as well, to provide information sort of to a broader community as well. So this can be ordered through the CAMH online store for $4.25. It can also be read online for free, breaking down each section. So you can go online to the CAMH website for more information, or you can click on the link here. And for a free sample copy of Making the Choice, Making It Work, you can also use this email address as well. And yeah, more information here. So I hope that these two resources are helpful. I'm happy to answer more questions, and I'll pass it over to you, Perlin. So thanks a lot, everyone.
Jean. Okay, I'm just going to close the presentation 1 second. Whoops. Done. All right. Thank you so much, Jean, for your presentations. So right now we are opening it up for questions. If you go to the questions function and send your questions in, we'll start answering them. So we actually had a whole bunch come in while the presentation was going on. Let's see. So most of them were just asking when and how the resources would be available.
Yeah, absolutely.
Which you did already answer in your
Yes.
presentation, so that's great. Okay. Someone was wondering if there was a similar document available in schools? Sorry, I'm just trying to open this right now. I can't.
To the best of my knowledge, there isn't anything specific to schools. And again, I know that many organizations have very different needs and are working with different demographics. So there's very specific concerns there and needs to be addressed. But to the best of my knowledge, there isn't anything in the school system that looks at opioid overdose prevention using naloxone. That said, different school boards might have different policies, but to the best of my knowledge, there isn't anything.
Our needle syringe program at Algoma Public Health in Elliott Lake, it's not advertised in the Ontario Naloxone kit map. How do we get that information on that site?
Oh, that is a good question. And like I said, there are a number of updates that will be taking place with the with distribution hubs, and so it might just be a matter of the ministry just not updating that. That's a good question. I'm not sure. But I'm sure that the ministry would probably want to know that that's not available and not online. So I would encourage you to maybe send an email over to the ministry and let them know that naloxone distribution point isn't reflected on that.
Another question, are there any examples of what other campuses have done around fentanyl? And I think this is not a question for you, actually. Neither is it for you. It's actually a question for us. So this webinar was more a basic kind of introduction to opioids and very kind of just explaining what it is and what the crisis is. If you wanted more information on kind of specifically in the post-secondary role, how it is applicable, our conference next week, which is happening at the Marriott, this October 30th and 31st, Ben Bridgestock from Algonquin College is going to be speaking. He has a workshop on called Post-Secondary Harm Reduction-Based Approach to the Opioid Crisis. And then that is actually going to go into a lot more detail surrounding what they have personally done at Algonquin and maybe what the other campuses have done as well. Hope that answers that question. Okay, another question. One thing we are navigating on our campus is delivering education and prevention with various international student groups where substance use and talking about substance use may be stigmatized. Do you have any thoughts or strategies for reaching out to the different cultural groups and safely opening the space to speak about these kinds of topics? I feel like this is a question for you folks over at BC, perhaps. No?
Well, we do, so a lot of the work that we've done through changing the culture of substance use has been focused on engaging various populations on our campuses around dialogue and other ways of kind of reaching out. And so they haven't been specific efforts around opioids in particular, because that project really wrapped up most of its efforts last year. However, what we found is a number of the tools that were developed by campuses were what we think is more broadly applicable than the areas where they were piloted, which was mostly around alcohol. So there was actually an initiative by Simon Fraser University that was intended to engage international students in their residences and actually I think in the broader campus community environment. And so they actually did, I believe they were cooking workshops with the students and then used those workshops as a way to bridge and engage with their international students, because they found that the students were really interested in learning how to cook, and this was a really interesting way to engage them. And so I would suggest looking on the healthycampuses.ca website, where you can find access to these resources. There's a resource tab for published resources, and I believe that particular tool has now been published on there. Oh, maybe not yet. So if it's not published on there, what often happens is there's a community tab at the top of the page. Anyone can join the community, and once you join the community, you can find resources in process and I would hope there's a copy of it within that portion.
It'll be coming soon.
Or it'll be coming soon.
But there are, hopefully soon, but there are a number of resources relating to dialogue and actually how you can engage your various groups on campus in conversations that can include meaningful discussion about, really dialogue about issues related to drugs, including opioids, and challenges that people are facing, and opportunities that there are for them to support one another and to find help and this kind of thing.
Okay, thank you. Someone is asking, is there a known street name for fentanyl? What would we see students calling it when speaking to another student?
My understanding is they're using fentanyl as the sort of general term, and there are folks who are actually among the student population, and I think fentanyl is very common and the term that is being used. Most folks are not seeking out fentanyl per se when they're using. They might be seeking out something else. We know that fentanyl is being cut with a variety of drugs out there, including Molly or MDMA, which a lot of young people use these days as a party drug, cocaine. So what you'll find with a lot of these overdoses is, in fact, that especially among that population, they were seeking out some kind of party drug, and fentanyl happened to be cut with it, and they didn't know.
Yeah, and I think that and that's a great point. And I also think that really having an understanding as someone who might work on a campus to understand and recognize the signs of an opioid overdose is crucial, because, like you said, someone might have taken a substance that where they were expecting to have different outcomes or different feelings, and could potentially lead to an opioid overdose unexpectedly. So I think that's understanding and recognizing the signs of an opioid overdose are really important.
So if we are running up against time right now, so I think we probably just have time for maybe 2 more questions. One is, what are the components of an opioid prevention strategy to prevent opioid misuse? Not overdose, but specifically misuse.
Not prevention of overdose, but specifically misuse. Is that I don't know, DC, if you would want to.
I mean, that's a good question. I'm not sure there is a comprehensive strategy that has been developed yet. One piece, and I think what we were trying to highlight a little bit in our presentation, was the idea that a lot of the strategies we often employ as a comprehensive approach, or think about as a comprehensive approach, are typically regulatory efforts. And in this case, a lot of the regulatory efforts that have been employed have actually precipitated the push and tip into an actual crisis. So they've actually in some ways exacerbated the problem. And so when you think about misuse, the reason we're really trying to promote a dialogic approach is because it's a way to engage your campus community and engage young people to help them develop their own strategies on the campus that is relevant to your campus community. And so it's working with students to develop your strategy as opposed to kind of working against them or on top of them to try and help them, tell them what to do. So I'm not sure there is a comprehensive strategy out there. I don't think anyone's figured that question out. But I really encourage you to look at these resources more in depth and start to think through how you might develop your own strategy. Do you have anything to add to that?
No, I concur, Katrina, that showing some trust in the ability of individuals to think things through and giving them an opportunity to talk things through with each other and relate to each other, and not just with their peers, but other members of the community that they have good relationships with, These sorts of things can be really, really important in helping to set the kind of context and conditions in which people are a little more intentional and deliberate and careful in their use and considerate in the way that they relate to others.
Yeah, and I think also keeping in mind too that people use substances, whether it's opiates or any other substance, for very different reasons, right? And so whether that's to experiment, to explore, to cope with pain, cope with trauma, cope with physical pain, there's very different reasons why people use substances. And so really having a non-judgmental approach to have a conversation about why someone is engaging with substances is a pretty great first step.
Perfect point. Thank you.
Yeah, even if we could guarantee a safe supply through a non-prohibitionist stance, we would still have the challenge of helping each other to relate to the challenges of substance use, because there are risks involved as well as benefits.
Mm-hmm.
Mm-hmm.
Yeah.
Great.
So last question. Gina, I think you said you had a question.
No.
For them? Oh,
No.
no. You want? Oh, okay. Never mind. All right then. Well, thank you all so much, and I apologize to our attendees that we didn't manage to get through the list of questions that people are sending in. Some of the more logistical questions, like where can the resource be available, I will follow up with you later. And thank you once again, everyone, for attending. And I'm just going to direct you to our website right now, which is campusmentalhealth.ca, where you can find lots of other resources in post-secondary mental health, and also all the recordings of our past webinars. The recording for this one will be made available on our website. You can also sign up for our mailing list on the website that we use to distribute our monthly newsletter, which contains all the latest relevant news from the sector. And last request, don't forget the survey that will pop up at the end of the webinar. Thanks, everyone, for attending.
Thank you.
Thank you, and thank you for allowing us to come and share.
No, thank you guys so much. It was really great. It was a really good resource.